Hello, everyone, and welcome to Report Back from San Antonio Breast Cancer Symposium. We're going to start our presentation within the next 1 to 2 minutes to let everyone sign in.
Danielle, I have a question for you.
Yes, what's the question?
Do you record this?
Yes.
Do you then put it on your website?
Yes.
Okay.
Hello again, and thank you for coming to the Report Back from San Antonio Breast Cancer Symposium. I'm Danielle Andrews, the Program Manager at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that improves the lives of women affected by breast or ovarian cancer through experienced peer support, accessible education, and innovative outreach, always for free. It meets women wherever they are, and especially in medically underserved communities, with the insight of women who have been there too, creating a nationwide network where women are empowered and feel less alone. SHARE's free services include support groups, educational tools, expert-led webinars, and presentations, a national helpline, online communities, and survivor patient navigation. For more information, visit our website, sharecancersupport.org. All participants will be muted during the presentation. When the presenter finishes speaking, we will open up for a question and answer session. You are welcome to submit questions during the presentation through the question pane in the control panel on your screen. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Dr. Timothy Pluard is the medical director at St. Luke's Cancer Institute and has a strong focus on metastatic breast cancer. As of recently, he has opened up a center dedicated to the comprehensive care of metastatic breast cancer. So I would like to take this time to allow Dr. Pluard to speak a little bit more about his breast cancer center.
Well, thank you, and thanks everyone for joining. It's an honor to be here. So we opened just 2 years ago in October, the Kuhn Center for Advanced Breast Cancer here in Kansas City with some philanthropic support. It's been a long time. I mean, I've focused on breast cancer my entire career, and it became apparent to me a few years ago that the care of metastatic breast cancer patients really deserved a concerted focus and effort. We have increasing therapeutic options, improving outcomes. Patients are living longer, and we really haven't focused within that population of how we can improve treatments and how we can improve the quality of life so that patients with metastatic breast cancer can not only live longer, but can live better with their disease. And so our center really is comprehensive in terms of our team, includes not only medical oncology, radiation oncology, but also a psychologist, a nutritionist, a full-time social worker, a exercise therapist, as well as a spiritual practitioner. And we a routine new visit here. Everybody is, all patients are seeing all of these disciplines initially, and then we collectively as a team meet together and then formulate our recommendations, and then I present the recommendations and review that all with the patient and their family, and we video record those consultations, and we also have the ability to remotely video conference family members in, excuse me, and then they're given a disc with their consultation so they can go home and review it. So, and we have a very strong emphasis on clinical trials. So we have 16, I believe, active clinical trials for metastatic breast cancer patients. And our goal is really that we have a clinical trial option for every patient at every treatment decision point. And so our clinical trial accrual rate is generally hovers right around 20%, which is far above the national average of 3 to 5% of patients. So we're committed to that. That's the only way we're going to improve the outcomes, is by better therapies. So that's a little bit about what I do. Fortunate to have a great team, and so then I'll move on to giving you an update. It was entitled San Antonio, but I took the liberty of including some interesting data that came out from the European meeting in Munich in October. So with that, we'll get started. So I thought I would just do this and break it out by the clinical subtypes that we typically focus on in terms of breast cancer. So ER positive, HER2 positive, and then triple negative, and then some miscellaneous things if we have time, and really talk about some new developments and where they fit in the current landscape of treatment. And all of this is going to be focused in context of metastatic disease, so keep that in mind. So just to set the framework for ER positive breast cancer. So right now, the standard treatment for first-line therapy of metastatic breast cancer is an anti-estrogen, either an aromatase inhibitor or fulvestrant, in combination with CDK4/6 inhibitors, one of the three that are available on the market: palbociclib, ribociclib, or abemaciclib. And all of them seem to have very similar effectiveness. There's a little bit difference in terms of the side effect profiles amongst the drugs, but on average, our median, the time to progression, or the time that the disease is controlled, is about 2 years, which is double what you would expect for anti-estrogen therapy alone. So the question is, what happens when you get to that point and the disease starts to progress despite the anti-estrogen therapy and the CDK4/6 inhibitor. And what's really important is when we have two agents in combination is to try and understand when the cancer starts to grow, it's undoubtedly developed resistance, but we don't know, is it resistant to the anti-estrogen drug? Is it resistant to the CDK4/6 inhibitor? Or is it resistant to both? And so understanding that would be critical in terms of trying to define the next step in the treatment and to personalize it based upon that, if at all possible. So what do we think about when we have progression on an aromatase inhibitor and CDK4/6 inhibitor first line? I would say right now that in general we would change both of the drugs, but maybe and perhaps that's not what we need to do. So if you think about, say you're on letrozole and palbociclib and you develop progression, the question is, could you continue letrozole if it's resistant to the CDK4/6 inhibitor and switch to a different targeted agent? Or if it's resistant to the letrozole, would you switch to a different anti-estrogen agent such as a SERD and continue your CDK4/6 inhibitor? And so we have some means of assessing this now that was presented, I believe at ESMO, and that is you can look at circulating free DNA from the tumor that can be identified in the blood and look at the mutations that are present there. So for instance, we know that with CDK4/6 inhibitors, for them to be effective, you have to have an intact RB, retinoblastoma protein, because that's what the CDK4/6 actually acts upon to prevent the cell from growing. So if it's not there, the CDK4/6 inhibitor can't inhibit anything. So we can actually identify, and they did in this study, some of the patients had acquired mutations in retinoblastoma that made them basically unresponsive to the CDK4/6 inhibitor. And likewise, other patients in the group had developed mutations in the estrogen receptor gene, the ESR1 gene, which now makes them resistant to letrozole. And we have some new emerging drugs that are designed specifically to work in the context of this ESR1 mutation. But the potential future is that we look at these mutations almost in real time in response to progression of treatment and help define the next step in the treatment cascade. So we really get to what we have been aspiring to in terms of personalized genomic therapy. So moving on from that, I want to talk a little bit about some background about PI3 kinase, which is an enzyme that's fairly ubiquitous in cells, and mutations in the PIK3CA gene are one of the most common mutations in estrogen receptor positive metastatic breast cancer. And it's associated with resistance to anti-estrogen therapy. And it's been historically very difficult to target due to the importance of this enzyme in normal tissues. But now, with greater understanding of the underlying protein and more specific drugs, we've been able to limit the side effects. Previously, the drugs had been effective, but too toxic for patients to tolerate. So what happens, and this is a very busy slide, and I don't expect to, and I'm not planning to explain it all, but basically, if you think about the way estrogen stimulates a cell to grow, it's the estrogen in the blood that then binds to the estrogen receptor, and that stimulates different genes and controls those, that leads to tumor growth. And what we want to try and do is block that pathway, right? So the problem is, though, it's much like a traffic jam on a highway. So if we block the primary pathway of with anti-estrogen drugs, there are other roads that can be utilized to bypass, bypass this blockade. And so they can still end up activating the estrogen receptor. So the goal is, and here is PI3 kinase, which is sitting right in the middle of this alternative road, is we now have a drug that can target that pathway called Elsif, which is an oral pill. And so we had the first results presented of this study, the SOLAR-1 trial, which was a phase 3 trial of patients, postmenopausal women or men, who had progression of their disease on an aromatase inhibitor and had a mutation in the PI3 kinase, the PIK3CA gene. And it turns out that about 40% of all women and patients in this situation will have that mutation. And so they were randomly assigned to get fulvestrant plus or minus ALP Elsif, and the other group got placebo. And what we saw is that effectively it doubles the time that the disease is controlled with the fulvestrant by adding the ALP Elsif. So this is a similar effect as to what we've seen in terms of the order of magnitude of when we add a CDK4/6 to fulvestrant in second line. And the side effects of this are fairly manageable. It does cause some hyperglycemia, which needs to be closely monitored and managed, and it can sometimes cause some skin rashes and GI upset. But the majority of patients were able to stay on the treatment for the duration. So this drug is now going to the FDA and hopefully will be approved and available soon to expand the repertoire of drugs that we have for treating ER-positive breast cancer, and more importantly, really attacking the most common mutation that occurs in ER-positive breast cancer. And while there's a lot of focus on HER2-positive disease and triple-negative disease because they are more aggressive, if you will, diseases, or viewed to be that, it's still the case that the majority of deaths from breast cancer are in patients who have ER-positive disease, simply because it's much more common. So this is good news for extending the endocrine treatment of ER-positive breast cancer. So I want to give you a second example because we had some update on this. And it's, in the last couple of years, it's become clear that even in clinically HER2-negative patients who don't have amplification of the gene, which is how we detect and define HER2-positive disease clinically, that even in those patients who are normal by IHC or FISH testing of HER2 may have a mutation in the HER2 gene, which essentially turns the gene on all the time. So it's overactive even if there's not numerically too many of the proteins. So about 2 to 3% of all ER-positive breast cancers that are HER2 negative, if tested, will be found to have mutations in the HER2 gene. And in lobular breast cancer, there's a higher incidence. It's 4 to 5% of patients with lobular breast cancer may have these activating mutations in HER2. So these can be detected either in blood, similar with the cell-free DNA that we talked about earlier, or on biopsies of metastatic sites. And these tumors actually respond to a combination of blocking the estrogen receptor with fulvestrant and blocking HER2 with a oral pill called neratinib, which is actually available for extended adjuvant treatment of HER2-positive breast cancer, although it has a lot of diarrhea, and so and its effectiveness is limited to the ER-positive population in the adjuvant setting. So we know now that this, in 2 different clinical trials, has been shown to be an effective strategy, and again gets to where we want to go in terms of understanding the mutations. Where are we? Gets us to precision oncology by understanding the mutations of an individual and then partnering that with a drug that specifically targets that mutation. So we move from treating all patients the same to individualizing the treatment based upon the mutation for a particular patient. And this is a CAT scan of a patient actually that has an activating HER2 mutation. So just to orient everybody, this is the liver, and this is the tumor, in the metastatic tumor in the liver. And this patient had actually been on a multitude of anti-estrogen therapies and actually had received chemotherapy and was still experiencing progression of her disease. This is after 2 months of being on the neratinib and the fulvestrant. So we biopsied this tumor and found that she had one of those activating mutations in HER2, and with the targeted therapy, her tumor shrunk dramatically and rapidly. And it is still shrinking and under control now about 8 months later. Okay, so let's shift gears a little bit and talk about triple-negative breast cancer. So the challenge with triple-negative breast cancer is it's defined by what it's lacking. It doesn't have the estrogen receptor, progesterone receptor, or HER2 amplification. And so we really don't have readily identifiable targets. But we're starting to tease out some of the underlying biology, and there are probably 6 different molecular subtypes of triple-negative breast cancer that may need to be treated or addressed differently based upon those subtypes in terms of how we approach treatment. And we know that immunotherapy, which has been incredibly effective in other tumors outside of breast cancer, has really not made significant impacts in breast cancer. But triple-negative breast cancer tends to be more responsive to immunotherapy than either HER2 positive or ER positive disease. So just as a way of background again, in terms of what these immunotherapy drugs do, these anti-PD-L1 drugs, which probably have seen advertised on television, Keytruda or Opdivo, there are probably a dozen different ones in development. But essentially, part of the function of the immune system is surveillance and to identify abnormal cells, abnormal tumor cells, because they're making proteins that are not normal, and that becomes an antigen for the immune system to recognize as being foreign and then attacking the cell and killing it. But what the tumor cells do is they express this protein called PD-L1, which binds on a T cell, and basically it's the stop, it's the checkpoint. So when your immune system gets activated, that there are some brakes on it so that it doesn't get overactive and start attacking your normal tissues. So, which if you think about when you get sick, you get the flu, your immune system has to activate and kill the virus or the bacteria, but then it has to go back to its resting state. And it's through these checkpoints that the immune system is regulated. So what the tumor cells do is kind of usurp this, and they signal the T cell that they're fine and it should stop attacking. So what these drugs like pembrolizumab do is actually block this. So they block the PD-L1 signaling, and so the T cell remains activated and can mount an immune response against the tumor. So what do we know about immune checkpoint therapy in triple-negative breast cancer? Well, we know that the earlier we utilize it, the more effective it is. So in several studies using pembrolizumab as a single agent without any chemotherapy, in first-line therapy, the response rate is about 18 to 20%. And many of those response rates are durable, so that they're lasting up to 2 years in one study where patients were remaining on immunotherapy to keep their immune system activated, and their disease was remaining in control. So it's a little bit different than chemotherapy because we know that chemotherapy develops resistance after use for a period of time. In the immunotherapy, if we can activate the immune system and hopefully keep it engaged against the tumor, then it's doing the work. So there is some evidence that when you give chemotherapy in combination with these anti-PD-L1 drugs, that the chemotherapy killing the cells, releasing all these abnormal proteins, actually helps stimulate the immune system in the context of being activated by the anti-PD-L1. And so we may have synergy between chemotherapy and immunotherapy. So we start to marry the old and the new to improve the effectiveness. So this was the widely publicized trial results from Impassion 130. So this was a randomized trial in triple-negative breast cancer in patients who had not had previous treatment for metastatic disease. And they were randomly assigned. Everybody got chemotherapy with Abraxane, and half the patients received atezolizumab, which is an anti-PD-L1 antibody, and the other group got placebo or essentially just received the Abraxane. And so these are the results, and I guess it may not show up that well in the colors, I'm sorry. But essentially, with the addition of atezolizumab, you improve the progression-free survival from 5 months with chemotherapy alone up to 7.5 months, which does not seem like a huge difference. But more importantly, when you look at the overall survival of these patients with metastatic triple-negative breast cancer, with chemotherapy alone, their overall survival was just over 15 months, which improved by 10 months to 25 months with the addition of the atezolizumab. And that is really a remarkable difference. And it's also consistent with what's been seen in other vaccine trials or immunotherapy trials where the response rates and the progression-free survival may not be dramatically different from a statistical standpoint, but the overall survival, because of the long-lasting effects of the immunotherapy, are more substantially impacted. So this has now, I think, become the new standard for triple-negative breast cancer in the first-line setting. It is pending approval by the FDA, which hopefully will be forthcoming shortly. A couple of caveats about the study. The patient, the tumor has to be PD-L1 positive, so you have to have a test on the biopsy to know that there is PD-L1 present on the immune cells that are infiltrating the tumor. But it only has to be 1% or more. And so by that criteria, about 40% of all triple-negative breast cancers would be deemed PD-L1 positive and would be eligible for this treatment. And then there's a phenomenon called pseudoprogression, which can occur when we're treating with immunotherapy, and that is that if you're effectively stimulating the immune system to reactivate, there may be an influx of immune cells into the tumor, and that may actually make the tumor look larger on CAT scans or imaging. And so we actually have to monitor differently. So if you see that, the patient, if you're doing well, but the tumor looks bigger, then you keep on going with the immunotherapy and the current treatment and see if it eventually starts to get smaller. So this is really a landmark because this is the first immunotherapy in breast cancer that is likely to be approved. So hopefully this will improve outcomes for triple-negative breast cancer patients with metastatic disease. And then I want to switch to just HER2-positive disease for a few minutes. There were not any major HER2-positive studies presented, but we are waiting some major trial results on some new drugs that hopefully will be forthcoming soon. So I'll just touch on those briefly. So margetuximab is a anti-HER2 antibody that is slightly different than Herceptin in that it has been engineered to more effectively engage the immune system. So Herceptin actually acts in two ways when it binds to the HER2 on the cancer cell. One is it stops the signaling of the HER2 protein to cause the cancer to grow. But secondly, it's an antibody, so it tags the cell for the immune system to recognize and kill it by something called antibody-dependent cytotoxicity. So margetuximab has engineered to make the part of the antibody that the immune system recognizes to make it more potent. And so the trial that's been completed, actually, just recently, compares standard chemotherapy with Herceptin versus the same chemotherapy plus margetuximab to see if engineering a better antibody towards the immune system can improve the effectiveness of therapy. The second trial that is still ongoing and hasn't completed yet, but will soon, is a trial looking at an oral HER2 inhibitor called tucatinib, which in combination with Herceptin and a chemotherapy drug, capecitabine, is being studied in HER2-positive patients, and importantly, including HER2-positive patients with brain metastases, because tucatinib does get into the brain very well, whereas Herceptin and other drugs don't get in as well. And so the hope is that this combination will be effective and will have some unique effectiveness against HER2-positive disease in the brain, which, as we have been improving control of the disease overall, and women with HER2-positive disease are living much longer, the brain has become increasingly a challenge in terms of trying to control disease there. So tucatinib would be a welcome addition if it turns out to be effective. And then I think there's an emerging number of drugs that are currently in clinical trials, which are antibody drug conjugates. So the technology is to take an antibody like Herceptin that can target a particular cell, in this case a HER2-positive cell, and link to it a very potent chemotherapy drug. So then the antibody binds to the cell, ultimately gets taken up by the cell, and once inside the cell, the chemotherapy is released. It is the Trojan horse model, if you will. And Kadcyla, which is currently on the market and actually is going to move into the adjuvant setting for select patients based upon some other trials presented, is an antibody drug conjugate. It's Herceptin conjugated to a very potent chemotherapy drug. So this strategy is effective. We now are seeing the second generation of these antibody drug conjugates. There are a couple of them in clinical trials right now that we are participating in, and these have some different effects from Kadcyla in that the drug may be released within the cell, but then may also not only kill that cell, but can be move on once it's outside the cell to a neighboring cell. So it has a bystander effect of killing. So these drugs may actually be effective in some of the tumors that are clinically HER2 negative or HER2 low, those that are 2+ by IHC but negative by FISH. And so they're being looked at not only in the traditional HER2 positive patients, but also in these low expressing HER2 negative patients. So we expect that we're going to see in 2019, hopefully, the results of some of these trials that can lead to new treatments. So I think for the purposes of time, I will stop there and see if there are questions.
Hi, Dr. Pluard. We have a lot of questions for you, so thank you for presenting for us. One of the first questions, you spoke a lot about triple-negative breast cancer, but are there any specific therapies or any upcoming therapies for triple-positive metastatic breast cancer?
Yeah, so good question. So by triple-positive, ER, PR, and HER2-positive, we still would focus those treatments under the umbrella of HER2-positive disease. But I think that we have probably underexplored the combination of anti-estrogen therapy with anti-HER2 therapy. And there may be an opportunity in that area to combine those.
Okay. The next question, is there any specific therapies for metastatic inflammatory breast cancer?
There are not any specific therapies for metastatic inflammatory breast cancer. Inflammatory breast cancer tends to have some different genetic abnormalities that may be particularly targetable, but in general, we would treat them based upon their underlying disease. So whether it's HER2 positive or triple negative, which, inflammatory is generally one of those two in most cases, although they're rarely ER positive cases.
Okay. The next one is more if there are any therapies in regards to metastatic lobular breast cancer.
Another excellent question. So lobular breast cancers, historically have been very hormonally sensitive. And in particular, I think it's critically important that every patient who has metastatic lobular breast cancer have testing for HER2 mutations, because with the rate of 4 to 5%, that's a significant number of patients who would be eligible for treatment with neratinib and anti-estrogen therapy with fulvestrant. So right now, that's somewhat of a unique therapy because it's more prevalent in lobular, but we don't have anything specific at this point.
The next question says that this person says that they are stage 4 de novo and they have had no evidence of disease for approximately 1 year. Is it still common practice to not get a mastectomy?
Yeah, that's a good question, and there's been a lot of effort to try and understand is there benefit or not to mastectomy in de novo stage 4 disease. And I think there's a couple of randomized trials that were outside the U.S. That basically concluded that from an overall population, it did not appear to improve survival. But I think it's highly individually dependent on whether to do it or not. It depends upon the extent of the metastatic disease, depends upon the age of the patient, the physical performance status of the patient. But certainly in patients, there are patients who have limited metastatic disease, what we call oligometastatic disease, where they may have just 1 or 2 distinct sites where they have spread, that we sometimes are more aggressive in terms of treating those patients with the hope of long-term survival and potentially cure.
Okay, so our next question is, can you explain the difference between somatic and germline HER2 mutations?
Sure. So germline mutations are what is inherited from your parents. So we all get 1 copy of each gene in our body from our mother and the other from our father. So germline mutations are those that we inherit. Somatic mutations refer specifically to mutations within the tumor that are acquired as part of the process of becoming cancerous. So that's basically the difference. And so when we do genomic sequencing of a tumor, ideally we compare that to the patient's normal DNA. So you can just tell whether it's a mutation that's in all the cells or which would be germline, all the cells of the body, or if it's a mutation that's just limited to the tumor cells, which would be somatic.
Okay. So we've heard a lot about 23andMe, and they've just received their first ever FDA authorization for a direct-to-consumer genetic test for cancer risk. So they can tell individuals if they have the BRCA1 or BRCA2 mutation. For people who rely on 23andMe, what might be some of the pitfalls that their consumers might encounter?
Well, I think the biggest pitfall that I would foresee is the interpretation of the results. Because, one, it's not always black and white, right? So there can be changes in the gene which are called variants, which may not affect the function of the gene. And it generally requires someone to sort of explain this to the patient, a genetic counselor generally, because you may have these variants that at this point we cannot tell whether, or cannot say with certainty, whether they increase the risk of breast cancer or not. So it's that interpretation, and then the fact that, you know, you have to also interpret it within the context of your family, particularly when you're testing individuals that are not affected. So, for example, if there are multiple members of a family who've had breast cancer, and say for discussion that the mother had breast cancer and passed away and has 2 daughters. So now those 2 daughters get tested and they test negative. So that means one of 2 things for those daughters. Either their mom did not have the BRCA gene and therefore could not have passed it down, or she had the gene and they were fortunate enough not to inherit it because it's a 50-50 chance. So if you knew her mom had the gene and they didn't inherit it, then their risk is at the population, the same risk as the population in general. If their mother didn't have the gene, but they still have a very strong family history, then there's something else that is driving that breast cancer risk that we don't understand, and those daughters still remain at high risk. So it's those situations that, you know, are somewhat complicated, that they need to be interpreted in the appropriate context.
Okay. So our next question is there any specific therapy for ER positive with the CDH1 mutation for metastatic breast cancer patients?
So CDH1 is frequently abnormal in lobular breast cancer. And right now, there isn't a specific drug that's been shown to effectively target that mutation.
Okay. So you mentioned oligometastatic disease, yet it's rarely discussed at MBC conferences. When you defined it as 1 or 2 slides, is that actual number of tumors with a region of the body? I'm sorry, that doesn't make sense. That makes sense? No, that's weird. Does that make sense? No? Okay.
So you want me to try and clarify it?
Yes, please.
Sure. So here's what I mean by oligometastatic. So, and I'll give you real world examples. I have 2 patients in our center who were young and at the time of presentation had a single metastasis in their liver. And we went ahead and treated them with systemic treatment. And they responded, but not completely in their liver. So one of them, we actually went in and resected the liver lesion. And in the other one, we did stereotactic radiation to that single lesion in the liver. So it's that type of thing, that type of situation where to treat aggressively to try and provide long-term control, and you know, we hope in some situations potentially cure those.
Okay. Can you see it?
No, it's just.
So we have another question. It's in regards to the results from Impassion. Are they all comers or the PDL1 positive subset?
It's the PDL1 positive subset that benefits.
Okay. So another question here is, what impact does microbiome health have on breast cancer? microbiome health?
That is a great question. And I don't know that we know the answer at this point. But what's very interesting is from some preclinical experiments that in mice that manipulating the microbiome, and that is so what the relative bacterial composition of your microbiome. And so just for everybody on the phone, so we all understand, when we say microbiome, we're referring to the billions of bacteria that reside in your gut, and what are the relative compositions of the various species of bacteria. And so there's been evidence that different bacteria in your gut can kind of prime the immune system to be more active and more responsive. And so there have actually been some studies in mice where you can actually take the microbiome of one mice who's responding to treatment, give it to another mouse who's not, and they respond. So, but I don't think we are at the point where we understand it in detail enough to know how to manipulate it effectively.
Okay, so we have another question. It's regarding late recurrences, specifically 10 to 15 years later. Is there any new findings in regards to the prognosis or treatment?
Well, I mean, I guess I would say in terms of prognosis that most of the time those late recurrences are going to be the ER positive breast cancers, and the time to recurrence is one of the strongest predictors of the long-term outcome of metastatic disease. So the longer the time between your initial treatment and your subsequent recurrence is a better prognostic factor. We tend to treat them essentially the same as we would someone who relapsed at year 5. Those who relapse very shortly after finishing or relapse while on adjuvant endocrine therapy, we treat a little bit differently because they tend to have a more aggressive cancer. But the late relapses, we treat very similar.
Okay, so the next question, do you have any thoughts on bone boosting drugs? For example, it says Somatic is given monthly, but after 5 years, it's now given quarterly.
Yeah, so there is actually a randomized trial that looked at that question, so that after 1 year of monthly treatments, could you go to every 3 months for subsequent treatment? And it turned out that the every 3 month was just as effective as the monthly treatment with fewer side effects.
Okay. So the next question is, can you stop long-term Herceptin use and Perjeta after 5 years of no evidence of disease?
They're great questions. We don't know the answer to that, but and it's a very hard study to do. It may be that the utilization of circulating free DNA may help us in that regard to answer that question. But my personal experience is, and I have patients, a couple of patients who've been on, over 10 years, is that they don't want to stop. They're quite happy to continue on since their disease is completely controlled, and they don't want the risk of stopping because we actually don't know what's going to happen.
Okay. Has there been any new data on lowering the dosages of tamoxifen?
I'm sorry, on what doses of tamoxifen? I missed.
Is there any data lowering the dosages of tamoxifen?
Yeah, so there was actually, I didn't talk about it because it wasn't related to metastatic disease, but there was data looking at 5 milligrams of tamoxifen as opposed to 20 for treating patients with intraductal or lobular lobular carcinoma in situ. So, and that was effective. If you look compared to full dose tamoxifen, they didn't do a head-to-head comparison, but the reduction in the risk of recurrence was the same for 5 milligrams as it was for 20 as was seen in the studies with 20 milligrams. So there is that potential option. Now, we don't know in invasive disease if the same holds true or not, but it's certainly something worth studying.
Okay, so we're probably going to do 2 to 3 more questions as we are running out of time. But the next question is there a timeline for drugs to evolve from progression-free to overall survival drugs?
If I understand the question, I think the question is, what's the relationship from progression-free survival to overall survival?
Yes.
So in almost every trial, at least with standard treatments, perhaps not the same with immunotherapy, but we always will assess progression-free survival first, because overall survival takes a lot longer. And I mean, obviously overall survival is the goal. It just is complicated by, subsequent treatments after the drug under study has been stopped. So in general, you need to have an improvement in progression-free survival to see improvement in overall survival. But the treatments after that particular drug can make it very difficult to assess because they can be very different between the two groups.
Okay, so our next question is, when Xeloda fails in treating metastatic breast cancer, what is then the next best approach for estrogen-positive patients?
Well, I mean, I guess it depends a lot upon what preceded the Xeloda. So if, oftentimes I would say Xeloda is the first chemotherapy regimen that's utilized for ER-positive breast cancer. And I think it's important to make sure that that one has utilized all the available anti-estrogen approaches, assuming that there still was response, including everolimus, which is frequently probably underutilized due to some initial experiences with mouth sores, but that's been rectified now with preventable with steroid swishes. So it's hard to, say specifically. I would say in general, Taxol is often used as the next chemotherapy drug by many oncologists. And there are actually some ongoing trials looking at oral formulations of Taxol, one of which we're participating in. And if those prove to be effective, so that there was an oral version of IV Taxol, that would be incredibly useful from a quality of life standpoint for patients.
Okay, and then our last question is in regards to triple-negative breast cancer. Which subtypes are more susceptible to immunotherapy? Which subtypes of triple-negative breast cancer are more susceptible to immunotherapy?
So the subtypes, there are various classifications of the subtypes, but essentially they include the basal subtype, which is the majority of them. Then there may be 1 or 2 immune subtypes, and then there's a mesenchymal and an androgen receptor subtype. So it's likely that it's those immune subtypes that are more likely responsive to immunotherapy, but I haven't seen data looking at immunotherapy analyzed based upon those molecular subtypes. They did look in the Impassion trial for other factors that might predict response, and it turned out that it was only the presence of PD-L1 on immune cells in the tumor that was predictive.
Okay, well, I'd like to thank Dr. Pluard for an informative program, and thanks to all of you for participating. Please take a moment to fill out the survey at the end of the webinar. It may take a minute for the survey to download. Thank you again, and thank you again, Dr. Pluard.
Thank you, and thank everybody for joining.
Okay.